So, this one's not going to be as hilarious. So reminder, our futures team, we're pretty small, so we're only working on 2 futures that we're trying to systematically create. One is the future, a completely different future for home care, and I'll explain why. And the other is seniors living and housing, and that's the thing after this. So those are the 2 next things. So I'm going to go a little bit deeper, and this is really to give you some ideas of how we're taking our approach. Maybe we can find some ways to collaborate, because we're an open book. We want to work with anybody who wants to work like us. Okay, so this was a quote from 2015. The home setting and healthcare services will become so synonymous that they might not be called home care anymore. Rather, they'll just be modern healthcare. That's how healthcare started, right? House calls. The poor people had to go to an institution to get care. It was completely natural and normal for care to come to the home. And as kind of some of the top scholars have predicted, like Clay Christensen, it's coming back to the home. And that's why I'm here. I was working in Europe, having a great time, and St. Louis recruited me and said, can you come lead futures for Canada's largest nonprofit home care agency? And I saw this future, home and aging adults. And I want to be part of building that, and that's why I do this. So a couple signals. So we just wrote a report, and I'm happy to share this with you. We had a master's thesis student scan the world for the signal of what we call the homespital. So we're seeing more and more of these modalities, protocols, treatments that used to be relegated to institutions are being done in the home. Very little in Canada, but we looked around the world and we kind of bucketed them into diagnostics at the home, so labs, imaging at the home, sleep, vision testing, hospital at the home, infusion services like chemo, dialysis, antibiotic infusions, of course mental health and brain health, and then other kind of one-offs like clinical trials at the home. And so we kind of wanted to see what's going on. Is this here? Is it prime time? Is it ready? What are the barriers? So that was the scan we did. So kind of this idea of high acuity or institutional centers no longer needing to have constraints of time, distance, place, and space, and the home being the setting. How would that work? We even looked at surgery at the home that's happening. The other we're seeing is an explosion of completely new business models in healthcare that are before the hospital or after the hospital, pre and post-acute. So these have a lot of different words: hospital to home, hospital at home, bundles. So more and more we're seeing these big complex health systems or hospitals reconstitute their mission statement. So Jefferson, which is I think 12 healthcare orgs in Philadelphia, this is their new mission. We're healthcare with no address. Completely porous walls, relative to big institutions. Kaiser Permanente, which is the big U.S. health system, about the same size as Ontario, they've had care anywhere as their dominant paradigm for now. I think they're on 12 years. They stopped building medical centers. They will not. And they've grown from 10 million to 13 million people without adding a single new bed and not a penny of extra cost. Right? They absorbed all of that, 30%, with other modalities and channels. And we just met with their top 3 priorities right now are mental health, more care anywhere, and their third one is called Focus Home. So they have an office of transformation that is just there to basically take care and get it out of Kaiser and into the homes. And they're learning from us. That's a first. Women's College Hospital in Toronto, you guys might remember the story. This was a typical academic center in University Avenue. It was supposed to merge with Sunnybrook Hospital, another big academic center. That fell through. And their board said, what are we going to be when we grow up? And it wasn't like they all decided unanimously. There was like very big anguish and disagreement. But they decided we're going to be a hospital with no beds. So this is a hospital, you do surgery there, lots of things. No one sleeps there. They redid their whole business model to get you out and be fully ambulatory. They took surgery length of stay down from 5 days to 12 hours. But you don't just do that through quality improvement. So other language, they now branded themselves as Canada's first fully virtual hospital. And then Mercy in St. Louis is a hospital not without beds, but without patients. Literally no patients go to this hospital. What's a hospital? Okay, my hospital in the Netherlands that I worked for a year, so we were a pretty big center, 15,000 people, and all these signals, you know, they saw too. And they said, we need to redevelop this hospital for the future, and we're not going to just keep creating the old way. And so they designed a plan to take them down from 1,000 beds to 500. And that's despite a 40% increase in demand. They have designed their business model to take 70% of what was happening at the hospital and push it out to wherever it makes sense, mostly the home. So basically strips your hospital down to all a hospital needs to be, OR, ER, and ICU. Right? That's the kind of things we're starting to see around the world, you know, enabled by tech. At HIMSS, which is the big health IT conference, it actually is this week in Orlando, I think like 40,000 people go from around the world. The Dutch like take over HIMSS, and they have these posters. This is actually a picture of a poster, how they're kind of imagining, and this is their Ministry of Health, the Dutch smart home. And they, you know, they use language like from the waiting room to the living room. When they formed their last kind of coalition government in the last election, minority government, they split healthcare from one ministry into three. The cure ministry, so that's hospitals, drugs, therapy, cure. Care, primary care, home care, elder care, and then public health, and had a separate minister for each. They're moving budget, $2 billion taken out of the cure budget and put into the care budget, and there wasn't rioting in the streets and ads on the, you know, subway about how we're taking, you know, care away from patients. It made sense in an aging population with a big dot goal of moving 50% of care by 2030 out of institutions and into homes. That's what the elected government has put as their big hairy goal. Right? 50% of care out of institutions and into homes. I don't know about this province. In Canada, home-based care is about $3 billion on 60. Right? It's very, very minor, just like virtual care. So that's just my only modeling I ever did when I wrote an article for the hospital magazine. That, you know, we really, you know, home is where health care will dominantly be, and when it's needed to be in institutions, it's going to work that way. So that's kind of what we try to obsess about. So that was our starting point for this, you know, this new model we're imagining to really transform what home care is and what it can be. And this is not just a one-off little point solution. This is a major system change. So we really had to put a lot of infrastructure. And we gave it a brand. We call the model the H.O.P.E model, and I'll explain it in a sec. Our mission statement is to spread hope and happiness, so we had to link it to that. But we're really kind of problem solving for 4 key stakeholders where today's models of home care just aren't working for them. Given everything I just told you about in the Future of Aging book, and just demand, and that this sector, home care, is like kind of the orphan, ugly cousin child of healthcare, right? It just hasn't gotten attention, metrics, capacity. So our clients and their families, our nurses, St. Louis itself, how are we going to be a viable organization if we keep doing home care the way we have been? And then our health systems who are trying to keep sustainability. So this didn't just happen when I showed up. This is actually part of a journey that this organization that's 112 years old has been on. So we kind of coined, I think in the 70s, if not earlier, our philosophy of care, which we always called person and family centered care, PFCC, way before healthcare decided it should be patient centered, or at least say it is. So we've had that as a methodology. We then built a framework and a model of nurse-led community care called the Nurse Care Manager, where nurses take care of a community. That kind of got taken away as we industrialized home care, but we had that asset. In Ontario, there's these best practice spotlight organizations, so we were one of those for nursing. And then we built infrastructure to kind of start to remove hierarchy and supervisors and put more layers between our clients and the top. and move to more of a coach model. And if you follow what's going on with organizational theory around the world, hierarchies are dead. Those is not how we're going to solve problems in society, whether you're government or a company or anything. And so we're starting to build capacity for coaching. So kind of all this had been going on, and then at the same time we started to see that in the Netherlands, Buurtzog, which is kind of this no management model of home care, has really been growing and spreading. They went from 2006 to 2014 from a kind of a one cell of 4 nurses with no managers to 14,000 today, with 50 people total that don't touch patients. That's it, right? I contrast that with most of us. What's your ratio of admin to frontline? So Buurtzog kind of really exploded in the Netherlands with a really interesting business model, lots of valuation. And they're now in versions of this model spreading to 26 countries, like Taipei and Germany and Belgium and the UK, in China, Australia, and Kaiser Permanente is now trying to adopt the Buurtzog model as part of their Focus Home. We have been meeting with these guys for quite a while, Zayna, Liz, and it's one thing to agree with the model, it's a whole other thing to actually try to do it, because it challenges everything about how we organize formal medicine. So, but they're building infrastructure, and there's now a global movement. I think it's kind of like your blue zones, but even more international. And so put that all together, our CEO and our chief clinical executive, Nancy Lefebvre, wrote a white paper to say, what if we try a different way? And that was kind of what we put out to the universe in 2017 of the whole model. And our metaphor was, this is just taking community nursing back to the future. That's how it used to be, but then we industrialized it, we productionized it, and we brought a lot of bureaucracy and hierarchy, and can we take it back to its roots? And so that kind of led to me coming in and saying, okay, we've proved this, let's now start to make it a systematic model, and we call it H.O.P.E. So H.O.P.E stands for Home, Opportunity, People, Empowerment. Easiest way to describe it is a house, because we do home care, I don't know, a little cheesy. So the core of the model is we really start with what do people actually want to do with their life? Is their goal when they've maybe been in hospital or they need home care to go to church every Sunday? Is that what matters to them? What is it? Do they want to garden again? And then we translate that into a medical goal. We don't start with clinical goals. Very different from how things are done today. And then a couple pieces of it. It's a nurse-led model. So why nurses? Well, as you know, nurses are trained in the full spectrum, social determinants, all the way to some pretty advanced medical care. So that's kind of how they're trained, that's how they work, particularly in the community, so they can kind of cover the gamut. But a big difference is the accountability. So we built a high level of accountability, which is different from today, which is a very task-based accountability. Do your task, show that you did it, and don't hurt anybody. And I'll explain how. We've added more to the nurse-led model. We've made it 24/7 instead of only available during business hours, which is how home care is done today. And these nurses are manager-free, no supervisors. So they work as a self-directed team, which again, if you follow all the literature, corporate rebels and holacracy and all these new org models, that management-based execution can't move at the speed it needs to and give people power. So we wanted to test that. A big part of why we're able to do this is because we now tap the renewable resource called people, their communities, their families, and their environments. So it's not a one-on-one relationship with you and the client in the home. We're really empowering formal and informal networks as part of the care model, and then we enable that by tech and stuff. So our CEO and many leaders designed the model. We took inspiration from Buurtzog, piloted it in 2017 with 50 people in an urban, very high-risk neighborhood in Hamilton, Ontario, and got really good results, kind of like a proof of concept pilot. Like, can we even work this way? Do we get results? So that was kind of enough for us as a prototype to say, let's take it to the next level. I'll just skip these quotes. So we partnered with a foundation called AMS, and you know, some of these foundations started when we made Medicare in Canada. So a lot of money was sitting around for insurance, so this foundation uses those funds to catalyze the health system. So they wanted to partner with us to help us really now test this model to position it for spread and scale. So it's more of a proof of value pilot versus what we did before, which is proof of concept. And that's the journey we started. We're exactly a year in, a 4-year program to really test this model and design it for spread and scale. And I'll talk about what that looks like. A couple things, because people always ask, what is so different? Because when you look at these words, they're kind of what everybody says. So I'll just get to the heart of why this is so transformational compared to what we do. So the first one is we're doing fully comprehensive care plans. So when we go into the home, we're doing a comprehensive assessment, including a whole assessment of the caregiver. And we're designing, we don't call it a care plan, we call it a life plan. And we're measuring our nurses against the life plan goals, not the care plan goals, and not those metrics. And we're using InterRI, because Canada is part of this international network for this kind of more comprehensive assessment. Second big change, by being nurse-led, we're really maximizing scope of practice. We're giving our nurses autonomy. They haven't had autonomy. It's been centralized scheduling and supervision, and they got to go do their task. And now they got to use their judgment and become like an entrepreneur, taking care of a neighborhood and a community. Our nurses do the assessment. Our nurses design the life care plan, not the center, which is the way it's done today, at least in Ontario. And we're paying them on salary. This is a huge business model change. We're paying them on salary, and we're paying them about 40% higher than nurses get today. And at least in Ontario, that gets them on par with hospitals. Nurses. It's a big difference. So we want to test if we reinvent the 6 layers of management we used to have and we give them power, can we get the results and get them excited about nursing and keep retention and all the issues that affect home care right now. The third is it's self-managed. Like I said, there's no manager, but there's a coach. So you guys play sports, right? The stars are your athletes. That's our nurses. We're obsessed about them. But they need a coach, even though they're the best at their game. So we have a coach model that helps the nurses perform their best as a team, but is not their manager. And we learned a lot of that from the Netherlands, from Buurtzog. Our nurses do their own hiring, their own firing. They do their own training. We don't centralize that. Huge change. They do their own scheduling, and I think the only thing we've tried to keep fixed is geography. So we use the data from Buurtzog of what's the maximum geography that allows a nurse to really take care of a community and hustle in the community instead of like randomly getting a schedule and going wherever the center says. And then the fourth one is we've embedded a tech first from the beginning. So I don't know how it goes on here. In Ontario, our nurses are still paper charting. There's no intelligence, there's no communication. The only real data that's collected is for billing. And that's just not going to work in the 21st century. So we're building that from day one with a digital-first model. We're giving patients and families access to all the information that our nurses have, to the chart, to the care plan, to the assessment. We're doing remote monitoring and a lot more. So just to give you a sense of kind of how we're approaching this isn't just a care model that we're testing. It's really a theory of system change. So my best metaphor is the Matryoshka doll. Remember these? Right? So we're actually innovating at 5 levels at the same time. And each level has its own prototype. We're going to fail, we're going to learn, we're going to fix. So it's like those like Chinese artists with the plates spinning at the same time, right? So first, we're actually changing how people and their families experience care, and we're asking them to behave different. We're asking them to be engaged in their care, to read their data, to do remote monitoring, to consent their primary care physician to be part of the care team. So we're asking them to behave different because to date they've been largely passive recipients of care. The next layer of our Matryoshka is our nurses, and the whole model, like I just told you, self-directed teams, no manager, salaried, all those are innovations on a nurse model that hasn't changed in a long time. If that wasn't enough, we're massively pressure testing our own organization. So you imagine you have a 112-year-old organization with 9,000 staff who are driven to execute a business model that's been what it's been, and every antibody of the org wants to come and eat the foreign object that is the H.O.P.E model. Nothing in our systems and processes allows us to do H.O.P.E. It goes against our IT rules, it goes against everything, which is not a criticism. That's why it's really hard for the incumbents to do anything new, because we've kind of systematized out and stifled anything new. So we are transforming our own organization. If that wasn't enough, it's inter-organizational innovation. And we are behaving very differently now with all the other sister organizations, community support services, primary care, pharmacy, industry, government, all new relationships, sharing, openness, and it's hard. We get mad at each other all the time. Things fail, people screw up, on our side or on their side. So all this, and this can't be done through like fancy contracts and data sharing agreements. It's all MOU, it's very aspirational. It's a different way of working, so we're testing that. And then finally, we're actually innovating at the level of the Ontario health system. Because if this checks out, we're going to have to change policy, we're going to have to change payment models, we're going to have to change laws, right? And everybody is kind of out here to work with us. So that's the kind of scale of this program. Most people think it's just about the care model. It's not. You wouldn't put Zayna and her team on it if it was. So I won't get into too much details. I can share this, but just so you know how we structured how we're doing this system of change. The heart is what we call our lab. So very experimental. We try, we fail, we learn, we keep iterating. That's where we're actually doing the model, and I'll show you what that looks like. We have a real-time evaluation, so it's called a developmental evaluation. Very different from normal evaluation because we have a scientist embedded on our team, getting data every day, telling us where we're screwing up, and we're iterating and changing the model back and forth. We built at the same time a whole infrastructure to engage the ecosystem, change mindsets, change behaviors, educate, all your kind of, we call that stakeholder engagement, but it's deeper than that. So we have a kind of a systematic methodology there, and then I have a little program team of 3 underneath it all. I won't show you all these. So just to give you some ideas, so right now we just started, we launched our first 2 neighborhoods last year to test the model in our labs. So the first is kind of north of London, Ontario. It's this quite rural area, very underserved, pretty homogeneous population in terms of like demographic, but very rural and lots of needs. So we have a 4-person team there. We have about 25 clients per nurse. That's our caseload we're testing. Maybe the data is going to tell us it's too much, it's too little, I don't know. So we're 5 months into that one, and then in November we launched a North Toronto neighborhood, very, very dense urban. The whole geography is 1 kilometer, 30,000 residents in that 1 kilometer. It's all community housing, high-rise, extreme poverty, 30% are newcomers, high chronic disease, and a lot of crime, and there's no assets in this community. It's kind of been ignored. That's why our government partner asked us to go test the model there. So we just started there, and we're going to add a couple more. So those are some of our nurses that we hired. So just to give you an idea of what's the difference from how things are done today. So today, at least in Ontario, when a client needs home care, everything in gray is the healthcare system. In Ontario, it's our regional health authorities. They're in the middle of changing their names right now because we just blew up the whole health system. But, you know, they'll give us a referral, they'll get a referral, they'll do the intake and the assessment, usually over the phone, and then decide a care plan, but I crossed out the word care plan, because it's really a service plan. It just says use different service providers, you go in the home and do these things. They kick that over to us. That's us, that's Bayshore, that's whoever, the agency based on market share and contracts. And then we kind of send our nurses or whoever into the field to deliver against the service plan that's being managed centrally by people who aren't in the home with the patient. And then it's all on paper, we do billing, and then any changes or discharge goes back to the grid, to the government. So that's kind of how it's done today. And in this model, an agency like ours, we're considered a vendor. We're considered a service provider. Go in, do the care that you're told to do, and get out. And that's not why people go into home care. And that's a lot of why we're really struggling. I don't know what your numbers are here, but retention rates are brutal in this industry. So in this model now, the government agency does still refer because the intake comes there, but now they're partnering with us to try a different way to do things and allocate the resources. Now the referral goes straight to our H.O.P.E nurse. They onboard the client. They do the assessment, but we don't call it assessment. We call it getting to know you. Getting to know you. And we don't say, okay, I'm going to sit down for 3 hours and do a 50 questionnaire so I can move to the next stage. We might do care the second we're in the home. They just get on with it. At some point, they'll finish the inter-eye assessment. They don't need to do it to open up care. We develop their life care plan, comprehensive, including the caregiver's plan, and then we deliver. We call it sense and respond. We just see what's going on and we adjust. So in the old model, and I went through this with my dad, if things look like they're getting worse, you put in a call. They might call you back in 5 days and come in a couple weeks and redo the assessment and redo the care plan. And then by then my father died, right? In this case, we'll change the care plan the same day. If it doesn't make sense to do the bath or whatever that day, we do something else. And we have great stories now from our H.O.P.E nurses. If the issue that day is I need to pay my TELUS bill because then they're going to pull my cell phone and then I'll have no connection to my grandkids, we help them pay the TELUS bill. Right? So that's kind of what we're working on. So just a couple other things of what we're starting to see. We're just getting our first 6-month data read from our research, but just some quotes. So this is one of our nurses. She said, my client always says they're very relieved that they have a team. So the H.O.P.E nurses work as a team, but there's a lead nurse. But the team gets to know every client in their neighborhood. And that's very different from getting 5, 6, 7 different people come into the house, which is the model today because it's a service model. This was a client, H. He called St. Elizabeth and he's like, oh my God, I love my nurse. He goes above the call of duty. We didn't ask our clients to do this. We don't even have a way to get feedback this way from our clients. But they're really feeling it from some of our early surveys. This is what the nurses are saying. So the biggest thing our nurses are saying is, I was so at risk of burnout, right? I'm trying to feed my family and get my hours in to get paid, but I'm seeing my clients suffer because I'm in the caring industry and I want to do more. And that, they don't have to trade off anymore. I have more control over my schedule. I can be more involved in my clients' care. I can be with them at the doctor's office. One of our #1 metrics is how many of you nurses have a relationship with the primary care doctor? Right? Are you going to those visits? Are you helping them? And if they don't, we wonder why. And often it's because the person might not have a primary care doctor, and we go get it. So this nurse, so with our nurses, we started by giving them tablets, and within a couple weeks they're like, no, I need a laptop, because we're doing pretty detailed documentation. So we gave them laptops, right? We give them whatever they need. They're our stars. They're our athletes in the kind of sports metaphor. So she was just saying, I got in, I clocked in, I did my charting. My charting time is cut in half, triple exclamation mark. That's our only triple exclamation mark. Another example of this in the model. So at St. Eliz, we used to have this program. I think we still do, I don't remember. One day of the year, I think in April, everyone in the front line gets $25 put in their bank account to go spread hope and happiness. So she was like, go do something, and then write a little letter of what you did, and then we share that. So we launched this one in November in Toronto, and the nurse asked her coach, can I get an advance on my hope and happiness dollars? Because I want to get something for my client. So then the coach, who's still learning this kind of autonomy, wrote me, she's like, can we get an advance on hope and happiness? I'm like, for what? And it turned out that this client was getting a personal support worker come in the house 3 times a week to give her a bath. And then in the care plan, we asked, why? And she said, well, I can't reach my back because of arthritis or something. So she said, well, there's a loofah you could get on a stick. to get, and she said, I can't afford it, right? Because this is a very, very poor neighborhood of Toronto. And so the nurse wanted to buy her a loofah. And I said, are you kidding me? You're asking me for hope and happiness? Go buy the damn loofah, right? Do what you gotta do. But then that triggered us to have an innovation. So we created a $1,000 petty cash for every nurse. Just do what you gotta do. And we'll evaluate it later. Don't wait for April. And she did that, not that this is the goal, but we eliminated the personal support worker. She didn't need it anymore, right? That's a very high ROI on like $2.50. This is probably the biggest one from our coach, so I don't know how you guys do home care, but for us, our supervisors audit the charts, but after the fact, to go back and say, oh, you could have done this with your wound or whatever. Now, because everything's in software, we're working with AlayaCare, it's probably the biggest home care software provider. My coach is auditing in real time every day. And then they have kind of case conferences once a week to go through and learn from each other. What did you do? What did you do? How did you deal with that? So it's like a real-time learning cycle. That's a key metric. Okay, so just last couple things about the model. Like I said, technology is huge, but on day one, we're not having people do VR and drones and, AI machines. So the way we designed it was pretty systematic. The first 6 months was just get base tech in, so at least we have a digital layer. And that's AlayaCare largely, it's our software. To do all the documentation, etc. Everybody has access if they've got consent from the patient. Big game changer though is our government partners have now given our nurses, I think we're the first in Ontario, access to two things. One is the whole home care billing system and ordering, so we can order equipment, supplies ourselves before we had to ask and call it in. And the second one is we have access to every data set. Hospital data, lab data, drug data, and we've got amazing stories. Like our nurses feel like they're in Wonderland, that they don't have to go in blind. Because you go to a client and you say, okay, what drugs are you on, or what labs, and they tell you, but it's not necessarily what it is, because they don't remember, they don't understand. So they can go in and search, did they do that test, or did they get that drug, or what dose, or whatever. They can just go in and do it themselves. So that's been huge. Now we're just rolling out the next, which is getting clients tools. So if a client doesn't have one, we give them a tablet with data, and they'll have, if they want it, full access through a portal for whoever they want to consent to all their notes, all their documentation, education content, and then for those who make sense, we're going to do remote monitoring, your typical vitals, oxygen, heart rate, blood pressure, etc. We have a fully digital capability, text, video, email. We're pushing out surveys in real time for prems and proms, so patient-reported outcome measures and experience measures, so we can get a pulse in real time. Instead of the way we do it today, we do a survey like 4 months after they got care for a sampling of the population. Caregiver tools, and then phase 3 is where we now work with more of the emerging tech. So we've got a couple things we want to test, like a voice assistant, some virtual reality tools, etc. Just on evaluation, so our research center leads our developmental evaluation. The protocol has 7 streams. I'm happy to share this with you. It's aligned to the quadruple aims. So these 2 are evaluating the actual act of implementing the model, costs, experience, outcomes, and then costs. But our advisory board encouraged us to have some independent evaluators, so we've also invested in 2 academic centers to do a more system-level ROI. So at Western University, the business school is doing a detailed cost model of H.O.P.E versus usual home care. It'll be the first time a model like that's ever been built in Ontario. And then McMaster University, one of the top kind of geriatric care model health services researchers, Dr. Andrew Costa, he has access to all the ministry data sets down to the patient number. So he'll go after and pull the full, utilization of healthcare resources. So the fully loaded ROI. So that's kind of the evaluation. That's a lot of investment, but we needed to do this if we're going to ultimately make a case to change the healthcare system and our org. So we had to do that. I won't get into these insights. That's my team. So I'm kind of the co-lead. I'm the operator, Tazim's our clinician, there's our coach, Tori's our program manager, Brianna does all our tech, and we have one embedded scientist from the research center. But it takes a village. You guys know this. I mean, I reflect on what you're doing with Blue Zones. It's identical, right? You're just going to bring a whole constellation that wants to try new things with a methodology that's pretty sound, and that's what we're bringing, an infrastructure. So we have an advisory board, and all these organizations are kind of on board to help us out with cash, with in-kind, and lots of help and services. So it's been fascinating to get everybody to come on board. So we're now kind of in our spread and scale. So remember, we did the pilot in 2017. We're testing in multiple sites for the next few years. We'll do about 1,000 patients to get enough data by 2021, I think. And then we move to kind of our spread and scale, our planning for that. So, you know, a multi-neighborhood rollout. We'd love to come to Alberta, BC. We're talking to Quebec. And then my CEO has kind of a vision that we would set up, like we call it a H.O.P.E Institute. So imagine you come to the H.O.P.E Institute to learn how to do this model, and then you take it to your neighborhood and do it. We don't need to be doing everything. We just want to build capacity, because this is a lot of infrastructure to create at once. So that's kind of what we're up to. The timing in Ontario couldn't have been better. Do you guys follow the drama? Okay. So we just blew up the health system in the middle of my H.O.P.E deployment. This is like February. Ontario decided to go from all the silos, so there's us, home care, and the patient stitching it together, to this new construct called Ontario Health Teams. And it's been great for Zayna list because we work across the province. So I think we're on 40 of the Ontario Health Teams, so we're kind of in every neighborhood. And the design principles of Ontario Health Teams are exactly the H.O.P.E design principles. So this has created really useful muscle memory for the organization, because we're probably the most experienced in actually now doing this, and we can bring that to these other health teams, because these are the rules of the game to do an Ontario Health Team, and that's kind of what we're doing for H.O.P.E. So that's been a great byproduct, and I think it's going to set us up really nicely for spread and scale. So, okay, I think that's all I wanted to share. If you want to learn more, we have a website, we do webinars for the public, we did a summit, I think some of you came, and we now have a community of practice that's global, with Kaiser, with the UK, with Netherlands, Sweden, Germany, Australia, because we all got to learn from each other, just like your Blue Zones. I think it's almost identical, so I welcome you to join. Thanks, let's have a conversation.